Aortoesophageal fistula is a rare but highly fatal complication where surgery is the definitive treatment. For patients who are not suitable for surgery, endoscopy is an option to consider. Here we present a case where a patient had multiple thoracic surgeries, developed an aortoesophageal fistula but declined further surgery, hence we attempted endoscopic closure. These are the patient's pre-procedure imaging. On the left, we can see a CT image showing the esophagus marked in yellow. We see a collection around the TIVA implant with gas locules, and this collection seems to be abutting the esophagus. On the right, we can once again see another transverse section where there's a linear hypodense tract from the collection to the esophagus, and this is marked by an orange arrow. Endoscopically, there is a full thickness defect that was circular in shape, and this measured approximately 8 mm. The aneurysm from the thoracic aorta can be seen as a pulsatile mass protruding through the defect. There was pus extruding from the sides of the defect, and this was washed out. After our initial assessment, we used argon plasma coagulation in a circumferential manner to mark the defect. This was also done to promote reepithelialization of the defect edges. Our settings for APC were forced coagulation mode at 30 watts and a flow of 0.8 liters. We had to be careful not to apply APC to the aneurysmal pouch itself. We re-entered with a 17.5 mm teeth ovasco loaded. We also used the twin grasper to grasp the lateral aspects of the defect and suction the whole fistula into the cap. Following this, we deployed the ovasco and achieved closure of the defect and fistula. We then released the twin grasper carefully and inspected our ovasco. When attempting these complex endoscopy procedures, we have found a stage approach is useful. The initial endoscopy is for assessment, followed by treatment of the infection, be it through endoscopic drainage, followed by definitive closure. For closure of the defect, there are a few tools, namely hemoclips, stenting, OTSC or endoscopic suturing. In this case, suturing might be dangerous given we are adjacent to the thoracic aorta, and hemoclips we felt would not give us the depth of capture we wanted to close off the fistula as well. In our patient, while we did close off the fistula initially, a few weeks later, this caused the pressure to be displaced to another part of the endoleak, causing a new aortoesophageal fistula. Hence, surgery still remains the definitive treatment and should be considered the first choice for most patients.